Hello everybody and welcome to this Old Age Liaison Psychiatry Network webinar on diagnosing dementia in the acute hospital. Could we and should we? It's my great pleasure to welcome you here today, tell you a little bit about the Old Age Liaison Network before we get started. So we're founded by members of the Royal College of Psychiatrists faculties of Old Age and Liaison Psychiatry, and we include interested professionals from a range of medical and non-medical specialties. We hope to provide peer support, inclusive of disciplines in geography and access to great CPD, including today, and to raise a profile and develop the subspecialty of Old Age Liaison Psychiatry, which is relatively new still. We hope to provide opportunities for collaboration and integrated working with related disciplines and developing pathways, and also to lobby for improvements in mental health services for older people in the general hospital. So far, 350 people have joined the network. We've held 2 online webinars in 2021-2022, one on new liberty protection safeguards and one on managing delirium in the emergency department. And the recordings for both those webinars are available on YouTube, so we'll post a link to those in the chat. We've also had sessions at both Old Age Faculty and Liaison Faculty annual conferences. And in December 2022, we had a full-day conference as part of the Old Age Faculty Winter Meeting, which went really well. And we're hoping to do a further conference later this year, or possibly next year, depending on how things go. In the future, we'd love to run more webinars and hope to move the mailing list to an online platform called Mail, as that will allow everyone to communicate with each other rather than just waiting for us to communicate with you. So watch out for more information about that. As I said, we're hoping to run further conferences in the future and looking to set up a special interest group at the Royal College of Psychiatrists, which would hopefully provide us with a little bit of admin support because we're doing this all in our own time at the minute. So without further ado, let's move on to the main event. Diagnosing dementia in acute trusts, could we and should we? So we've got 3 speakers, around 20 minutes to 30 minutes of Q&A and panel discussion, and we'll finish at 4:30. Please use the Q&A box for your questions and use the chat box to say hi and where you're joining from. We'll be recording the session and uploading to YouTube, and we'll be doing some pre and post session polling. And please give us your feedback at the end. So unfortunately, this part of the webinar didn't record. So I'm doing this as a retrospective, but we did run a pre-session poll, and the results of that poll were that 79% of you thought that we shouldn't be diagnosing dementia in the acute trust, and 29% of you thought that we should. And we're going to move straight into Dr. Andrew Sommerlad's talk.
The needs, so that we're taking into account the needs of people with dementia. So for that reason, it seems important to me that we're able to recognise the presence of dementia when people are admitted to hospital. So our study was looking at how frequently this is done, and I'll go on to explain more. There's some work that's been done on this area. This team based up in Edinburgh did a systematic review to see how frequently dementia was diagnosed. This is in various different data sources like mortality data, hospital admissions, the second lot, or other sources. So in people who had been diagnosed with identified as having dementia, how frequently was it recorded? And it's this group in the middle here, 4 studies from Scandinavia. Somewhere between 1/4 and 1/2 of people admitted to hospital who already had a diagnosis of dementia had this dementia recorded during their hospital admissions, which seemed to us to be quite low, although obviously it's quite context specific. So the study, which was published a few years ago, and I'll link to it towards the end, but we looked to try and analyse how accurate dementia diagnosis in general hospitals in England was. We term this sensitivity and specificity, and I'll explain how we use these terms in a little while. We wanted to look to see how it had changed between 2006 and 2016, which is the data that we had, and to see which factors affected the accuracy of the diagnoses. So we developed this observational cohort study using routinely collected clinical data from 2 linked data sets. So everyone had been through a very large mental health trust, South London and the Maudsley, which contains clearly mental health services and also memory services, dementia diagnostic services. We got the records of all of those people. We used that as a gold standard. And then these data allowed us to look at their linked hospital records using this hospital episode statistics data, which is England-wide data from hospital admissions. So we could look and see what happened during admissions before and after their contact and their diagnosis by the mental health service. So there are two bits that we've looked at, both of which I think are interesting and relevant to this. For people who were assessed in the memory service and diagnosed as having dementia, we looked forwards to see whether if they later went into hospital, they had dementia recognised and recorded, which we think it should have been, so that at least the hospital was aware of the dementia status. And then for people who made it through all of their mental health service contact, whether that's contact because they were depressed or an assessment in the memory service and being deemed not to have dementia, if they got through the mental health service without being diagnosed with dementia, we could feel confident that they probably didn't have dementia, and we looked back to see if during previous admissions, when they should also not have had dementia, if that had been correctly recorded as not being present during their preceding hospital admissions. That's a real summary of what this study did, and I'll explain just in a little bit more detail. First of all, I'll explain the data. I mean, just to touch on, because it will hopefully be of interest to people, the data that allowed us to do this is really clever, which is the Clinical Record Interactive Search database, which was sort of pioneered and developed in South London and the Maudsley, and now available in lots of places nationally, and many of you will have access to this, I expect. So in a very large 1.2 million people catchment area for the Trust, we could identify all people aged 65 plus who either had been diagnosed with dementia or not, had been diagnosed with another condition between 2008 and 2016. And then for all of those people, access all the hospital admissions that they had in English hospitals, in English NHS hospitals, not private hospitals, and the diagnoses entered by the clinical teams who are caring for them. So these are the discharge summary diagnoses that the junior medical doctors are entering on discharge summaries, or perhaps also being supplemented by a kind of back of house admin team. So that's where we got hospital dementia diagnosis. The nice thing about this data set is that CRISP captures all of the kind of messy clinical records that we write in our routine day-to-day work and converts that into a research-ready database. So it picks out easy things that you can get out of clinical records like age and sex and HONOS scores, and also diagnoses that we correctly enter into the right diagnosis box on an electronic health record. But then it uses this natural language processing algorithms to delve into the free text, our clinic letters or our progress notes, which typically we wouldn't get useful information from, but it analyzes that and picks out additional information. So it might be able to get a diagnosis that's mentioned in a clinic letter, even if we haven't entered it in the right box on the electronic health record. So that's really nice because it adds to the structured fields and increases the accuracy of the data. And we're looking at diagnosis in this study, but the data has been used by lots of people in dementia studies, also clearly in studies of other mental health problems, to think about the effects of different drugs, as we did in this study of cognitive effect of antidepressants, disease monitoring, looking at progression of MMSE decline in people with dementia, up to the point of taking a cholinesterase inhibitor, for example. As I said, I think this is an up-to-date list of where CRIS is in place, but many of you will have some access to this. So I'll just go on to reiterate, I suppose, the design of the study here. So there's a cohort of people with dementia who were diagnosed, and we knew at the point at which they'd been diagnosed in the gold standard mental health service. We followed them through in their NHS general hospital records to see on each hospital admission whether dementia had been correctly diagnosed or recorded during that admission, up to the point of the end of our data in 2016, or to the point where that person might have died. That's what we defined as sensitivity. The specificity, meaning the sort of really thinking about, are there false positives? That's to do that. We took a cohort of people on the right who had, so in the kind of bottom right of the figure, who didn't get dementia at the point of their last assessment in the mental health service, and looked back at their preceding admissions when, of course, they should still not have had dementia. And we looked to say, hopefully, most of those people weren't incorrectly diagnosed as having dementia. We were concerned if there were many false positives, i.e. people who we thought didn't have dementia but had been diagnosed in hospital. And then the other analyses, I think, will become clear as I talk about them. So going on to results, I haven't given a lot of information here, but we have, the nice thing, construct this big cohort, 8,000 people who had dementia, 13,000 who went through the mental health service and didn't have dementia. And now I'll get on to the main bits of results. So I'll as I said, in this 8,000 people who had dementia, subsequently they had between them 27,000 emergency hospital admissions. We looked at emergency admissions because that's the time when that means an unplanned hospital admission rather than coming in for an operation or for renal dialysis, for example. So emergency hospital admissions, each of them had, I suppose, on average about 3 or 4 admissions. So 26,000 admissions. Dementia was recorded in 17,000 of those, which is 63%. So our sensitivity figure suggests that 63% of the time dementia is recorded in someone who has dementia and goes into hospital. The other half of this is the 13,000 people who had gone through the mental health service and didn't have dementia. Those people before that had 50,000, so roughly, again, 3 times as many admissions, had 50,000 hospital admissions, and so 97% of those admissions, they had correctly not had dementia put on their record. And then there is a smaller proportion, say 3%, of those admissions of people who we thought didn't have dementia. Dementia had actually been recorded on the hospital record. I'll come back to summarise those again at the end. So here we looked at time trends. So, it's just interesting to have data over this length of time. So between 2008 and 2016, there was a slight upward trend in this kind of what we feel as accurate recording of dementia in people who have dementia. So the figures are a little bit different here because of the way we only looked at the first year after diagnosis. But there was an increase from, say, 49% to 61% in that accurate recording, and that's a kind of a significant finding. So an upward trend of accurate recording. The specificity figure here, the picture is that there was, best way to put this, I think, is that there is a slightly higher rate of apparent false positive recording of dementia across the study period. So going to convert this 98.7 from 1.3% to 4.2% of admissions seemingly incorrectly had dementia recorded. Again, I'm going to try and explain why I'm not totally confident in that as an explanation. And then, as I said, here are the things that we found associated with the accuracy of diagnostic recording. So this is putting everything into a kind of exploratory analysis. What things were linked with a higher rate of false negative recording? So that means, missed dementia diagnosis in people admitted to hospital. There's a slight mistake there. So the first is actually that younger people had a slightly higher rate of their dementia not being recorded, as did people with milder dementia. people who were not agitated, people who were independent in their ADLs. All of those, as you might imagine, are markers of milder disease. So I'm sorry, I've got a few. I turned it around to try and make it all a bit more understandable. But so all of those things, indicators of slightly milder disease, meant that it was more likely that dementia wasn't recorded when those people went into hospital. Kind of important characteristics were that people from ethnic minority groups had a much higher rate of dementia being missed, and as did single people. So I think we can talk about the implications of that later. And here's the other side of this. So who was more likely to seemingly be falsely diagnosed with or incorrectly diagnosed with dementia? Those are people who are older, who had worse cognitive function, who were agitated, and who had impairment of their activities of daily living. Or you might suggest the markers of worse cognitive function. Okay. So those are my results, and I think I have a minute or two just to conclude. And I hope that this research gives a partial answer to the question of the seminar. So generally speaking, in hospital, pre-existing dementia is generally being diagnosed in around 2/3 of cases, and this is improving. So it suggests that existing dementia cases are being missed less often, and hopefully this, as I said at the beginning, would allow us to make better adjustments for them in hospital and to plan for their discharge. But there remains a substantial minority where dementia is seemingly missed, and this is also inequitable. Worryingly, it's particularly so in people from minority ethnic groups, people who are younger, who have milder disease, and who are single. So speculation would be that the minority ethnic group are more frequently missed because there might be language barriers, there might be less diagnostic skill in the medical team, and also maybe they are less aware, or there might be stigma in the patient and their families. Single people, of course, might not have an informant to be able to tell them. Oops. So, as my voice goes, it's clear that it seems that this research suggests that a small proportion of people are misdiagnosed as having dementia. I would say that this proportion is probably an overestimate for two reasons. I said that those misdiagnosed people tend to be older, cognitively and ADL impaired, and maybe agitated. Maybe those people do actually have dementia. And it's just that the what I view as being the gold standard service in the mental health team have not picked this up. It's also, even if that is not the case and they don't have dementia, the sample of people in this study, as you can imagine, are not typical of the general population. They're people who've gone into a mental health service. So in general, they'd be quite a difficult group to consider. So I guess to summarise, question, can we diagnose dementia? My view from this research is that I think we generally can, and the bigger problem that we have here is that we're not diagnosing it frequently enough in people who do have dementia, and that's potentially problematic. Should we diagnose it? I don't think I have an answer from the research for this, but I have some views, and I'm also looking forward to hearing the other speakers and for more discussion and debate about it later in the session. So here's the reference, and I might just put a link to it in the chat as well if people want to just go directly to the paper. It's a work from a number of us, and thanks to them, and thank you to everyone for listening.
Thank you, Andrew. Okay, Helen, I want to introduce you, Helen Croft, our next speaker, who hosted to the Old Age Conference inspired this subject. Helen is the old clinical lead for older people in the liaison team and Royal Derby Hospital.
Thank you for your kind introduction. diagnosing dementia in the acute hospital, could we? So my team have been providing diagnosis of middle and late stage dementia in the acute hospital for some time now. And the liaison assessment of dementia audit that we've conducted in our team is our attempt at understanding how well we measure up in this regard. So today I wanted to talk to you about the background and context of our memory assessment work, talk about our aims, why we completed this audit, go through some of our results, and provide you with an update as to where we are now. So when I was considering the context to this presentation, I thought this graph was a really useful place to start, because it's probably something that we're all very, very familiar with. We know that during the pandemic, the suspension of memory assessment services resulted in a drop in national, regional and local dementia diagnostics rates. And the result of this was that we saw a missed cohort of patients and carers who had been unable to access memory assessment services or who did not get referred on at all. We know that we're social creatures, and the impacts of isolation in lockdown created an acceleration of the condition, and that lockdown was particularly detrimental for the older adult age group and for people vulnerable to cognitive decline. Other issues, so we know that time to needing increased care reduced quite dramatically, and that created significant problems in acute hospitals, and in particular our acute hospital, around inpatient flow. And there was a significant impact on carers' physical and mental health. And this is something that we can testify to within our own team, having lots of telephone calls with carers and hearing some quite sad stories about how they've been managing at home. So pressure on non-specialist parts of the system grew, and we saw an increasing number of people with dementia occupying medical, surgical and rehabilitation beds. And all of this was on the background of reduced capacity in the social care system. So a reduction in residential and nursing home beds, and people struggling to get packages of care in the community. So what did this system pressure mean for us? Well, it meant that we accepted increased requests for memory assessment, and those memory assessments were for people largely with middle to late stage dementia syndromes. And the function of those referrals, the function of those assessments was to support flow and safe discharge, essentially to allow for an allocation of a specialist placement bed, dementia placement bed in the community. So the character of our referrals changed in our liaison team, and a de facto memory clinic was established during the pandemic period. And whilst we might have expected demand to reduce in the recovery phase, it's not abated. And this memory assessment work that we commenced during 2020 is now an established feature of our day-to-day work. Also, interestingly, it's now locally accepted that assessment of dementia in acute settings is necessary and part of a new normal. So whilst we've adapted to the challenges of the pandemic, we are not commissioned to provide these assessments, and the work is not included in psychiatric liaison accreditation standards. And in addition to this, there is no national guidance currently for completing memory assessments in acute settings. So when I was lucky enough to gain a promotion nearly 2 years ago, this was something that I thought a lot about and wondered how well we were doing within the team. So we decided to complete an audit, and that audit was to ascertain the quality of memory assessments completed by our team in line with relevant standards. And that was to allow us to understand areas of success and look for places where we could perhaps improve our processes internally. The second aim was to answer the question, do we need a memory assessment performer specific to liaison work? But in order to measure quality, and in the absence of national guidance, we developed our own standards within the team. And to ensure that these were robust, we were able to seek external advice from Professor Farouk Khan, and he is from our local NHS Midlands Dementia Network. And his advice and guidance was really useful. We'd originally considered just looking at the older adult age group, but we decided to make this an ageless audit. So the standards we created were by adapting existing guidance from NICE and MSNAP, and we felt were relevant to a psychiatric liaison setting, and that also importantly included the core components of memory assessment. In addition to this, in addition to the assessment standards, we also wanted to consider how well we were doing with our post-diagnostic support offer. And in some ways, that's in recognition of the fact that we're a liaison psychiatry service and that we don't have the resources and time available that memory assessment services might have to do this work. So we completed an audit of 50 memory assessments, and we found that we were completing over 25 assessments of dementia each month. Assessments were largely compliant against most of our assessment standards, and the majority of assessments were commonly conducted jointly by a nurse and a psychiatrist. Others were completed by our psychiatrists alone, and we also have a specialist mental health pharmacist in the team who is an NMP who is also involved in memory assessment. Unsurprisingly, we found that compliance against our post-diagnostic standards was weaker. And when we discussed this, we felt some of the issues that we'd experienced here were around patient presentation, so those very late stage dementias that we were seeing in the acute hospital. When we looked at subtypes, we found that we were most commonly diagnosing vascular dementia, probably unsurprising given that we're in an acute hospital setting. And we were also noted that we were given lots of unspecified dementia diagnoses. And again, we think this was around the stage of dementia that we were diagnosing in the hospital. For me, though, the most important information here is the people who we didn't give a diagnosis to. So 42% of our audit sample didn't get a dementia diagnosis. And for me, this feels like an area of success. Materially, as a team, we were able to rule out delirium or depression, for example. And if we were particularly unsure of the presentation that we saw, if we felt it was guesswork, we were referring on for a longitudinal assessment. In terms of the core components of memory assessment, we felt there were some really clear areas of success. So we were able to assure ourselves that we were looking at bloods, we were ruling out reversibility, really good percentages on considering strengths and needs and focusing on rehab potential here and what people still have to offer rather than what they've lost. We found really detailed documentation about mental state examination and formal cognitive testing. This was slightly reduced in compared to the mental state examination, and when we discussed this, we all agreed that there was lots of people that we were seeing who simply didn't have the capacity to engage in cognitive assessment, and that a more dignified approach for those patients was to just complete the mental state examination, look at neuroimaging, and consider the collateral history. Collateral history is collected in the team via the telephone calls. Some of our colleagues use the short IQ code. Other places of collateral history come from our ward teams, but we were evidencing that we were getting this information and communicating it in our assessment letters. A key and perhaps unsurprising area of success was around neuroimaging. And I think it's worth noting here that most of the neuroimaging that we're able to access within the team has not been requested for neurodegeneration. Lots of people in hospital who have potentially had falls or had CT heads for a range of different reasons. We've got access to packs, so we're able to review images, and a really good and key piece of our work here is that we've got really good relationships with neuroradiology, and we can ask them to re-report if necessary. Our post-diagnostic standards was weaker and noted as an area of requiring improvement. Evidence that disclosure of diagnosis to the patient was discussed was only 21%. And again, this is around the cohort of patients that we're seeing in these middle and later stages. We think that not only is it the cohort that's impacting our reduced results here, but also a lack of time resource within our very busy liaison team. And again, here it's worth highlighting that we can't replicate a memory assessment service model. However, since the audit was completed, I think some good news is that we work very closely with our hospital's dementia team, and they now provide the post-diagnostic follow-up for us. They benefit from the expertise of an Admiral nurse and contact patients at point of diagnosis, but also follow them up with a phone call home, which is a phone call at home, which is really, really useful. Other things that we're looking forward to at the Royal Derby Hospital is a specialist dementia palliative care nurse who is starting within the hospital in the next month. And we think that their role is going to be really beneficial to care provisions and care pathways for our patient group. So, in our conclusion, what did we learn here? What does all this mean for the assessment of memory in psychiatric liaison? I think we were able to assure ourselves that the assessments that we are undertaking were of a good quality against our own standards, whilst identifying areas for improvement. And we are using a QI methodology to implement changes within the team. We recognise that some of our assessment standards need to be adapted for use in a psychiatric liaison setting and in the cohort of patients that we're seeing. And we also recognise that we can't do this work in isolation. So perhaps a shameless call for collaboration here. Please do get in touch with me via my email address if this is something that interests you, and we'd really like to hear from you. I think importantly, we were able to understand that the function of assessments in the hospital is to support flow and safe discharge. And that by completing this work, we're also able to support the wider system. So our colleagues in secondary mental health services, community mental health teams, and our local memory assessment service, which currently has very high waiting lists. That said, we recognise that the best place to receive a diagnosis of dementia is in the community, and we don't wish to replicate a MAS model. I think it's really important to highlight here that we really very much enjoy our liaison work within the team. In terms of not being commissioned to do this work, we are at our ceiling of resource at the moment, and that means there are often delays in picking these assessments up. And within our team, we often use the phrase that these referrals need to be put on a memory clinic pile in periods of high acuity, and be very honest with referrals or referrers, and tell them that often these requests are not our top priority. Our other work must come first. So lastly, should we be doing this? Within our own team, there is consensus that our approach to this work is a pragmatic response to the real world problems that our patients face and the system faces. I recently shared this work with our colleagues at NHS Midlands, and system leaders there recognised the significance of our work in maintaining dementia diagnosis rates in Derby and Derbyshire. But what I'm really interested in hearing from today is clinicians, and what your thoughts are on our work in Derby. So we really welcome your feedback at the end of this webinar. That concludes my presentation for today, but thank you for listening, and looking forward to some rich conversation.
Thank you, Helen, for a brilliant talk. I'd like to hand over to Jane Fleming, a senior research assistant in the Cambridge Public Health and Primary Care Unit. Jane, all yours.
Hello, thank you very much. I'm just trying to get that up onto share onto the slideshow bit. Hang on. Slideshow. Okay. Well, thank you very much for inviting me today. That's as Mark said, I'm a senior research associate in Professor Carol Brain's Ageing Research Group in Cambridge Public Health. Delighted to be presenting today on behalf of colleagues I collaborated with on a project who at the time were in the University of Hertfordshire in East Anglia. So it was across the east of England. And a couple of publications that came out from this were published 5 or 6 years ago. So it was really interesting for me to hear from Annabelle, who got in touch about us sharing the findings at this talk, that it's still such a hot topic, because I have to confess, although I do work in my clinical role as a nurse in an acute hospital, I'm not involved in dementia diagnosis, and in my academic role, my recent research hasn't been in this area. So I'm looking forward to hearing from audience, as well as having enjoyed the speakers we've had so far today. That project, I should have said, was funded by the National Institute of Health Research, credit where credit's due. I know that for this audience, there's absolutely no need to be reminding you about the spate of reports earlier in the 21st century about the concerns that were highlighted for care of older people in hospital, particularly when it was picked up with the press and the public, quite rightly very concerned about the care of older people with dementia in hospital. And it coincided with research coming out that time on the prevalence of dementia patients in acute hospitals and their worse outcomes. And it's against that background that we had the introduction now more than a decade ago of the first nationally set commissioning targets for hospitals to identify which of their patients had dementia or marked cognitive impairment. And this applied to all patients over the age of 75 admitted to an acute hospital, all acute hospitals with unplanned admissions, for those hospitals to find and assess and investigate, and very importantly, refer on those patients. And although that was, you know, a nationally set target for quite a few years, it continued as other priorities came onto the national lists to be locally commissioned as with lots of different services, that dementia should be still a commissioning priority, of course with financial implications for non-compliance, and that's obviously served to embed the processes now that, as you've been talking about, are now routinely happening. What's worth I think reminding ourselves is that this was about case finding for dementia, not screening for dementia. National screening committees in this country and many others were consistent in agreeing that dementia is not a condition that fits the criteria for a screening program. But there was also no evidence base, if you like, for case finding for dementia, particularly in the acute hospital setting. So it has raised debate, which is raging still, and, you know, many questions. And the questions that the research project I worked with, I've highlighted there, or amongst some of the ones that clinicians were also asking too. I'm going to concentrate today on the first two questions here, because I've been asked to talk to you around the findings from the paper that came out of the first phase of our 3-phase study. The first 2 phases were using qualitative methods. And there isn't time to go on to all the rest, but we were in that first phase trying to map what was actually happening in terms of dementia case finding when it was still quite new as a nationally mandated requirement, through interviews with hospital staff and GPs, trying to get views and understand the experiences from both the secondary care and primary care side of how this was working in practice, what people thought were the objectives, what were the challenges, what were the perceived benefits. This was conducted across the East of England region, where there are 18 acute hospitals, and we managed to interview staff from 12 of those hospitals, where we were particularly approaching for interview people involved in the process, people like dementia nurse specialists and clinical leads for dementia, obviously liaisons, so old age psychiatrists, consultants at geriatricians, and so on. And GPs were recruited through professional networks and primary care research networks through the across the catchment areas of those hospitals in the region. Mainly the data were collected through recorded telephone interviews, but we did also conduct a couple of face-to-face focus groups in GP practices, which included other members of the practice team, practice nurses, and a couple of the admin staff involved in the process. So just to taste to hear the 3 main themes that emerged very strongly from these interviews and focus groups, which I'm going to come to in a moment, but just to give you an overview, fragmentation was a really strong theme in how differently the process was working in different areas. I think it's not news to anybody that barriers between primary and secondary care came up as a theme. And then we heard a lot about what people perceived to be the rationale or the aims and the impacts of what they were being asked to do. So first of all, on the fragmentation thing, this lack of standardization in a sense was not surprising, because these targets were introduced nationally, but with no particular national set way that people are meant to be doing this. So hospitals had devise their own systems and processes for rolling out this case finding for dementia. And there was big variation in who was responsible for the assessments, how assessments of cognition were being carried out, and other assessments that were leading into the dementia diagnoses, how that process was being documented, and how the findings were being passed on as well. Sorry, I'm getting my screen partly covered up by my little bar at the bottom. And it's not letting me move on. There we go. So at an individual level, we were hearing about very different ways of implementing this through involving different staff. It might be just junior doctors in ED, or on the ward. It could be from consultants and a whole range of other clinicians involved in assessments. And for some hospitals, because of this panic about losing financially if they didn't meet targets, they were specifically employing staff not involved in the clinical care team of a particular patient, but to be going around the hospital, make sure that assessments are getting done. Not surprisingly, with so many different clinicians involved, there were very different priorities being reported, and sometimes very low buy-in from some members of the hospital staff involved. This quote's from a clinical lead for dementia who's talking about the pushback he was getting from colleagues about it really not being worth the time, and it's a waste of time, it's not important to us, it's ridiculous, was the sort of feedback he was being given. At a system level, I'm sure many of you are aware of the lack of standardization of IT systems across the NHS, but for capturing this dementia case finding data and passing on that information, how it was being recorded, was very variable. Again, this was a consultant who had been involved in assessments, despairing about when she sees discharge letters where she says, I specifically said about cognitive impairments, and I can see that the GP hasn't got all that information. And from primary care too, we were hearing the other side of the story, and this was one of the big barriers. The general complaint about lack of communication when their patients had been in hospital. I mean, sometimes you don't even get anything. You usually get something, but sometimes you don't get a discharge summary. But GPs wanted much more than that. They wanted better explanation of the process. This GP was saying it might be helpful to know how far, how badly they fail or they pass the test, which type of test they're doing, rather than just being told there was some concern about cognition or and there was lack of clarity about roles. Again, a hospital consultant leading on dementia reporting that a lot of calls came through from a few calls, I should quote accurately, from GPs coming through asking, what is my responsibility? What are you asking us to do? And there was a worry about the wastefulness if this wasn't joined up properly, that when GPs lacked access to results of tests already done, then investigations were being repeated. One GP was telling us the patients getting mucked about because they're having to have more tests done, and it's really very poor cost effectiveness for the NHS because tests are being duplicated, and of course there's the experience of that for the patients as well, being sort of passed to and fro. In one of the focus groups, a GP was referring to a letter from the hospitals. If it says they need further treatment, well, why can't the ward make the referral? Then it would shorten the interval the patient's waiting. That sense of who refers and who's doing the investigations and taking it forward. There was considerable concern about the lack of clarity on what the impacts and outcomes might be, that because it was a nationally mandated target, had it become very tick box and inflexible, inhibiting room for professional judgment, that not only were GPs saying they didn't get enough information from hospitals. On the hospital side, some staff were very aware that they weren't getting anything back to know, so they couldn't measure what the outcomes were. This was from a dementia nurse specialist reporting, well, you know, that ticks the boxes. We fulfilled our sequin requirement, but there's no one seems to be assessing whether what we're doing is appropriate or correct, or whether the care plan is written in an appropriate way. And GPs in particular were questioning whether hospital was the right environment. I know that's the big question for today anyway, but they were worried about the potential for mislabeling. It's very interesting to hear Andrew's results in this context. This GP saying, you know, when they're ill, they're very often confused. I know perfectly well, because I saw the patient the week before they went into hospital, that actually they're functioning perfectly well and they don't need further referral. And some GPs were saying the hospital was only telling them about patients they already knew. You know, usually it's been people we already knew, and you know it's been flagged up by their family. So we're sort of monitoring it. There was quite a lot of cynicism about whether this was all politically driven. You know, David Cameron had his dementia challenge, and people wondered if politicians just felt they must be seen to be doing something, and was this diverting resources with no evidence of benefit? Was it actually worthwhile? I thought this was quite a powerful quote from a GP saying, I'm not really sure that case finding dementia is helpful in a world that is cutting services for people with dementia. And the focus of what people thought the aims were seemed to divide slightly, so that secondary care was focusing on diagnosis, and primary care was talking much more about what they could or should, or were they able to provide in the way of post-diagnosis support. It sounds like I've been raising lots of negatives, but it wasn't all that. One of the positives that came through very strongly, particularly from the hospital sides, was feeling that this move had certainly improved training about dementia. It was raising awareness about dementia in hospitals, and some secondary care clinicians were very firm about the fact that they were finding people with dementia unknown to primary care. You know, for people who would have been missed, who wouldn't have gone to their GP. I think it's great that we get an opportunity to pick people up in an acute hospital. And the other strong positive, and this came more, I think, from the hospital specialist nurses, this sort of comment, was that this was actually providing an opening for families, you know, that sense of relief. Sometimes they really appreciate it, and it'll open the floodgates, as it were. You've asked that question and suddenly they're, oh yeah, we have been having problems actually. So it's sometimes really helpful. Now, I know time is limited, and in the second phase of our study, we went on to try and hear a bit more from the carers and some of the people who had been flagged up as their dementia possible status being of concern in interviews with them. But I'm not going to share those results with you, but I'm slightly cheating in my summary slide and including a little bit of what we were hearing from them in that phase of the study. So just to summarize, I've talked about the huge variation in how this was reported to be working, you know, across just one region, admittedly of England only at that time. And the contrasting views that we were hearing, contrast both within professionals in the same setting and between different settings. We had some of that variation in attitudes also reported from patients and relatives, if they'd been aware of what was happening in the way of assessments, but often they were unaware of any of this having been conducted while they were in hospital. And overall, identifying concerns about cognition or possibly coming up with a firm diagnosis while in hospital didn't seem to usually lead to follow-up in terms of either GP recognition, because they claimed they were often aware before the admission, referrals for further investigation, or starting any new support services. So I guess some key messages are the not rocket science ones about information communication between a hospital where this has happened onto other clinicians in the community, is that it needs to be comprehensive, it needs to be appropriate and consistent, because without that, GPs can't effect any effective follow-up. And even with it, there were certainly loudly voiced concerns about the limitations of what support could be provided. Communication, we know in many settings is of course two-way, not only with the older people and their families themselves, but the other professionals involved in caring with that family, which of course we know is a skill, but it's also the question of time and commitment to that. So I think the other key things I wanted to raise was the fact that we felt we were coming up with some key questions more than answers from what we were finding in this phase of the research. A big one was what was at that time rather untested dementia case finding in hospitals, diverting scarce resources. How do we ensure that implementation of new public health policies is always accompanied by evaluation of the impact in a meaningful way? And that was beyond the scope of a small qualitative study, to look at the outcomes for patients, and certainly to look at the health economic outcomes needs further research with the kind of level of gathering information and linkage of routine data that could really find some of those answers. So I know we've now got a question and answer for all the speakers today, not just mine. Further comments and implications of everything we've heard today will be really interesting. If there isn't enough time, as Helen said, I'm very happy to be contacted by email, and I'll leave you with the citations for the couple of papers that came out of this research.
Thank you so much, Jane, and thank you to all of our three presenters. I think what you've done is, from different perspectives, from clinical perspective, from research perspective, using different data sets, different experiences, we've got a really good sort of stimulating discussion ahead. And so thank you so much for that. So Andrew, Helen and Jane, could you put your cameras on, please? The way that we're going to do this is that Liz is going to have a look, keep an eye on the Q&A and bring up some questions. What's been brilliant as other presenters have been talking is, particularly Andrew and Helen, you're going to need hand massages at the end of this session because you've been busily responding to people's questions in the Q&A. So that's brilliant. And I've also noted down some questions myself. So I'm going to sort of chair this bit and put the questions to the panelists. And Liz is going to keep an eye on the Q&A. So keep them coming in. But I wonder whether I might kick off a bit with a question to Andrew, sort of thinking about his session. One of the things I wonder is, and you were looking at sort of diagnosis in hospital, is whether the improvement in recording, it could be attributable to record systems that talk to each other. So mental health record systems talking to acute hospital record systems, and perhaps trusts that have that facility might be doing better in terms of recognizing that someone has dementia. Would you like to comment a bit on what might be responsible for the improvements that you've seen?
Yeah, that's great. Thank you. So, and it feeds into a couple of comments that were made in the chat and not in the Q&A. I don't seem to be able to respond to them, but pointing out, and I agree, that our study was not about we didn't look at kind of correct first diagnosis of dementia. We were looking at people who had already been diagnosed with dementia, who then went into hospital. So partly that is about, I mean, you know, for some of those people, there won't have been that contact, and actually they will have come in fresh into the hospital, and there would have been a kind of assessment process to think about whether that assessment process would have been happening in a kind of clinical context. I think probably more often when someone's admitted to a general hospital, you know, everyone is scrabbling around to get information. I think in 2008, that's when I was a very junior doctor at that point. Normally there weren't very closely linked electronic health records between different sources, but instead it might have been the case that you'd be getting a record from the person's GP, and you'd know from that point that the diagnosis was available. So in response to some of those comments, I would absolutely say that I agree that some of this is really about transferring existing information onto different systems. Yeah, I don't know. I don't know of any hospital system. I haven't worked in an acute hospital where data has been automatically migrated from primary care or mental health records into the acute hospital. But I mean, of course, someone coming into the acute hospital, they might be able to call on previous admissions and existing chronic diagnoses in those settings. So some of that process is, I do think is a you know, a kind of healthcare admin process rather than necessarily about diagnosis.
Brilliant. Thank you so much, Andrew. And I think it reflects, when we think about nationally what liaison services have available to them in terms of systems, there are services that are still using paper and pen, and services that are using more advanced systems like Epic, where I think it's much easier to accurately record and pull across diagnoses. So thank you for that. I've got a question for Helen. I've got a question for each presenter, and then we'll see what Liz has got from the Q&A. So one for Helen. In the work that you're doing, what's the relationship like between your service and the memory assessment service that might be serving that group of patients? And how might that have changed since you've been getting much more proactively involved in dementia diagnosis?
I think our memory assessment services recognise that we are easing their workload. I think there are times when we see patients who have already been referred to the memory assessment service but haven't been seen. Waiting lists are very long for those assessments in the community at the moment. I think overall it's positive. I think there is some concern around this, or misunderstanding around the stage that we diagnose at. So we don't diagnose people with early dementia in our team, and so there's some sort of perhaps misunderstanding around us perhaps doing that when we don't do it. I think the thing that is key though is that we can't provide that post-diagnostic support in the way that they can, and that really is a challenge. But overall, really good relationships with our colleagues in MAS and the community mental health teams. Something that has come out of this work, when I spoke to the older adult division within our trust and presented it to them, was that they recognised that actually they needed to do things differently from their side of things. And so they are looking at many more diagnoses being completed by community mental health teams rather than going straight to MAS.
Brilliant. Thanks very much, Helen. And another question sort of feeds into that a little bit, but perhaps goes to Jane, because you may have had some data through from your study about this. Is one of the things that makes me a little nervous about making a new diagnosis is I don't want that patient to miss out on the opportunity of starting some treatment. And of course, because we're seeing them in hospital and then often they leave hospital quite quickly, is that there's a risk of people falling through the net in terms of getting on their dementia drug. So Jane, I don't know whether there's anything from your study that might give a sense of how well things are followed up, not just in terms of post-diagnostic support, but getting people on the right medication.
Thank you. Yes, and it was only from the second phase of our study where we were talking to carers and patients themselves. So it was the limitations, of course. This was all self-report, and it wasn't, you know, in our scope to access medical records and check this. But we were repeatedly told that they never heard anything more about it from the GP, and there was a small minority who were started on medication, some of whom had then stopped it. Some of whom had actually already been started on medication by the GP before, but it wasn't something that was following on naturally for everyone as a result of that. And perhaps not surprisingly, given what we were hearing about how poorly some of those findings were coming out of the hospital to the GPs.
Thank you, and I think that does sort of reinforce my main worry, and you know, presents a bit of a risk that we have to work with. So thank you for that. Liz, I wonder if you want to pick a question for us.
Yeah, I think that some of these questions have been answered in the chat, but there's broader implications, which is that about the capacity of liaison psychiatry to manage this as a new process, given the number of referrals we see per week. And someone's commented, well, you know, 25 assessments per month is quite a lot. So it seems to be shifting activity and resource, or taking burden from memory clinic and moving it onto liaison psychiatry. So I wondered, yeah, whether, Annabelle, we could explore that a bit.
Yeah, I wonder, so Helen's been at the sharp end of this. I wonder if you might like to make a comment about that.
I think we're not commissioned to do these assessments. We've got a very well staffed and well resourced team at the Royal Derby Hospital. What we have found is actually that our nurses really enjoy this work. It takes them away from some of the other aspects of psychiatric liaison work around the kind of ED presentations, and actually they really value the contacts that they have with older adults and really enjoy these assessments. I think when we go through very significantly busy weeks, things get more difficult, but we have very honest kind of relationships with our referrers, and you know, we have to be very honest with them and say the other work takes priority. This is something that we will do as an extra. So we tend to have sometimes lots and lots of referrals on our whiteboards, and I think it does add to pressure, but I think the nurses within the team would rather see the older adults because they enjoy that work than us stop doing that.
Brilliant. Thank you very much. Liz, are there any other questions that you'd like to put to the panel?
I think just some general questions. Like, I wondered if, Jane, if you'd done any kind of cost analysis in your project to see whether, because we think we're helping, but sometimes we're just shifting the cost somewhere else in the system. And although we want to give patient-centred care, the best persuasion for resources and services is costing things. Yes.
The University of East Anglia colleague involved was a health economist, and the second paper we brought out from this study tried to look at some of these impacts just through case studies, because we didn't have the resources to do the full data linkage and actually looking at how, for instance, Annabelle's question about how many people really got onto medication, and you know, what did it lead to. That would have been lovely to do, you know, even just across one whole hospital, let alone a region. But if you go to our second paper, it gives you a little bit of the costing estimates he was able to do just from some case study work. So not really in the detail that we would have liked to be able to do it.
Thank you, Jane. A question that actually has come from Josie, and maybe I'll put it to Andrew to start with. Josie reflected that actually the greater availability of CSF and blood biomarkers for dementia might impact on our ability to make diagnoses in the acute hospital setting. Would you like to comment perhaps on what that might look like as they become more available to us in future?
Yeah, that's great. Thanks. Yeah, I mean, my understanding of dementia biomarkers are that, you know, the closest things that to becoming sort of routine would be blood-based biomarkers like markers for p-tau, which is a marker of Alzheimer's disease. Clearly, that's a marker of Alzheimer's disease pathology, but not a marker of kind of cognitive. Clearly, you know, doesn't necessarily reflect cognitive severity and would not be used and shouldn't be used as a way of diagnosing dementia. It's probably more to help in the differentiation between different dementia subtypes and you know, potentially identifying people at risk of going on to develop dementia. And you know, there's a huge debate to be had around that. So, I mean, I suspect it might be helpful at some point in increasing confidence in diagnosis, but I don't think it's necessarily a first-time thing. I don't know if there's any implications about its use in kind of acute settings. You know, whether the accuracy of those tests is compromised at all by acute illness, dehydration, inflammation, infection, all of those things. But that's certainly something that you'd have to consider and think about. I mean, I was interested because I saw one of the comments in the chat around toolkits for diagnosis of dementia. And again, my view in this is really that where diagnosis is uncertain, and I think that, Helen, you said the same thing. You're not diagnosing mild dementia. This is the value of this is thinking about, well, these are people with more, you know, moderate to severe dementia who might be bouncing in and out of hospital and not getting the diagnosis cleared up because there isn't an opportunity to do so. And those where the dementia is relatively clear cut, those are the people who we should be thinking, you know, let's do this now so that the care can be put in place. But I know, sorry, I just note the comment and the question about whether anyone knows of any resources that have been developed for diagnosis of dementia in liaison settings. I don't know the answer to that, but wondered if anyone does know of any other kind of routine ways of making diagnosis.
So people might perhaps put some answers in the chat if they've got some ideas or resources that might be helpful. Liz, there's a lot, I can see lots of questions in the Q&A. Do you want to pull something out for us for the panel?
Yeah, certainly. I think a really important point, which is really practical but interesting, and I think this is probably one for Helen, is just that basic thing of having a private place to assess someone on a busy ward. And, you know, have those private conversations with relatives. So it seems a really basic problem, but I think in liaison we have these practical problems all the time, and I wondered, Helen, how you got around those.
In terms of collateral history, this is usually obtained by a telephone call prior to going to see the patient or afterwards. So we take those phone calls in our office. Can be quite long and time-consuming pieces of work to do. I think in terms of finding a private space to do these assessments, that's really difficult. Where we can take patients into to side rooms on the wards, but again, often the patients are have problems with mobility. So it's a challenge, and especially when you kind of add in sensory impairment and kind of being physically unwell. These are really difficult issues to navigate. So we often get referrals for people who aren't quite medically optimized, and we ask referrers to to refer back to us at the time of discharge planning. But I don't think I have an answer as to private spaces and the best therapeutic environment to complete a mental state examination or formal cognitive testing on busy medical wards.
Perhaps following up a little bit on that in terms of the process of assessment, but also what comes out of the assessment in terms of the behaviour of clinical teams. There was an interesting observation in the Q&A that once somebody has a diagnosis of dementia, that the clinical team may take a different approach to care, and that approach to care may be less active. I wonder if you have any observations about the impact of your assessments on the care that person then receives in hospital, and how we might mitigate against the possibility that some aspects of care may be pulled back on.
I think one of the things that was highlighted from our audit was that we take a very strong strengths-based approach with patients, but there is this risk that as soon as we say this patient has vascular dementia or Alzheimer's dementia, that the ward staff and clinicians will immediately think that they haven't got capacity and make all decisions for them. I think the questions around rehab potential is an area that we need to explore further. We do sometimes, and I will say professionally, fudge our impression to allow for rehab to be considered over kind of going to respite placements.
Yeah, that reflects a little bit my clinical experience and how we need to so strongly advocate for our patients. Liz, are there other questions that you'd like to raise?
I'm just looking through the questions here. I think there is this kind of received wisdom around, isn't it, that this 3-month idea that you won't be seen in a memory clinic within 3 months of an acute hospital admission, and also around delirium. But then we know that in 1/3 of people with delirium, this is work from Thomas Jackson, there's a previously undiagnosed dementia. So actually the delirium should be a marker. And I wonder how I guess all these questions are coming to you, Helen, but so for Helen really, how you got over the parallel assessment between delirium and dementia. And I guess for Jane, whether delirium did come up much in your studies as well, but perhaps Jane first.
Did he say Jane first? Yeah.
Yeah, Jane first.
It certainly did. It was one of the GP concerns, and I was going to come back in on the last bit of conversation about whether, in line with what Annabel was saying, tied with her clinical experience, we certainly were hearing from clinicians their hesitation to give a dementia diagnosis because of the impacts that would have on discharge destination, or difficulty in finding a discharge destination. Sorry, that's not answering the last question, but certainly that was one of the issue about being acutely ill and delirium, and how well hospitals were untangling that was something that GPs raised. I think probably hospital staff felt that they were taking that into account.
And then I think we were going to put that similar question to Helen around sort of untangling delirium and dementia in the context of an acute hospital admission, but also it brings in another question of sort of reversible causes. And when we're seeing somebody in something of a snapshot, how do we make sure that actually we haven't got somebody who's who's got room for improvement? So perhaps we'll put that one to Helen.
We see a huge amount of delirium in our acute hospital, as I'm sure exists everywhere else up and down the country. We will often get referrals asking if it's a dementia, if it's a delirium, We often put this back to our referrers and ask them to contact family members with the question of how were they last week, which often provides the answer to what they were looking for. I think sometimes referrers are a little bit scared when people say things like, well, look for the collateral history, and they say, you know, we haven't got time to spend an hour with a patient's family on the phone. And yet the question is really, were they okay last week? And if they were, then we won't be offering a memory assessment. In terms of untangling delirium and dementia, so difficult. Again, it goes back to kind of collateral history and family members and understanding levels of confusion before they came into a hospital or from a few weeks before. And I think it's especially difficult to kind of pull apart progression of disease and delirium when we're in an acute hospital. In terms of our assessments, we sometimes provide diagnosis when people have delirium at kind of very moderate to late stage, if we are satisfied that the clinical picture fits. But again, where we're not, we will refer on to our colleagues in community mental health teams and ask them to review that patient. I think we don't refer on to MAS anymore because I think it's looking at about a 9-month wait locally to be seen by MAS. So we know that they'll be picked up much quicker in the community teams.
Thank you so much. We could carry on for another hour at least, but unfortunately we've got 5 minutes until the end of this session. So our presenters, thank you so much. What an interesting set of talks. And also you've been so busy and detailed in terms of answering the questions. In this last couple of minutes, there may be some bits and bobs in the Q&A that you could still respond to. So we're going to keep you at work until 4:30 if there's any bits that you can respond to by typing. And I'm going to hand over now to Krish to do a wrap up, ask you a final question and give you some information. Thank you everybody who's been involved today, presenters, hosts and the audience. It's been a really, really interesting session. Over to you, Krish.
Thank you, Annabelle. What an interesting hour. I think probably this is worth almost a whole day of webinar that we tried to condense it into an hour. And thank you again to all the speakers. The questions clearly indicate the interest, the passion with all of you providing that. Again, just to add a couple of questions, somebody talked about scan, which is again a bane of our life, people not reporting or re-reporting. But it is really interesting that all
looks like Krish is having a little rest there.
Frozen.
Josie, do you want to take over?
Yeah, we need to
That's
redo
my-
the poll. So just saying, please don't leave before you've done the poll again. Is
Yeah.
that right if I launch it, Chris?
Yeah, go on then. It's number going down, Josie.
We've got quite different results to when we did it at the beginning, which is very interesting.
So can we
we've
have
got
the
got
poll?
168 participants. So
Okay,
wait
let's
for a
see.
few more people to vote. So yeah, get your votes coming in. Just give it a few more seconds and then we'll share the results. But yeah, it's very different to the last one. Yeah, keep voting, please.
Yeah. I think we've got the 116 out of 116,
Yeah,
but we've got
all right.
167. Yeah.
Share the results now.
Yeah. Very good. So we have shifted the mindset, which is good. People are getting. But thank you, Josie, for organizing. Just to wrap, final thing. We do not have the facility to give certificates. I'm sure you can use the recording as well as the webinar confirmation for your own CPD, and hopefully please give your feedback so that we may be able to make it more formal and regularly support. Finished, Josie. So if you could scan the QR code, you may be able to give your feedback, or there is a link in the chat as well.
Thank you. Thanks, everyone. We'll just leave this open for a few minutes to get people's feedback.
Yeah. Yeah, we'll send a recording, Shabna.
Okay, 3:30. So sorry, 4:30. I'm going to end the webinar now. Thank you so much, everybody.